Welcome back, everybody. This is going to be Chapter 3, Evidence-Based Practice. Very important because when we think about what we do clinically, we should have a scientific reason for everything we do. So this has really been in the past 10 or 15 years in sports medicine and healthcare in general, is whenever we're trying to decide what to do, right, clinical decision, we have models or diagrams or methods of doing what's best, right? So everything we do is proven scientifically. So these clinical decision-making models or evidence-based practice, it has to start with research. So let's use an example of a torn ACL. There's 3 tests we use: the Lockman, the pivot shift, and the anterior drawer. Because even though each test is designed to test the ACL, when we use them in isolation, sometimes we get bad results. But when we use them all together, it increases our accuracy, right? And that's been proven with scientific research. So now that there's a test cluster, we can improve our clinical decisions, right? Is the ACL torn? Yes or no? So sometimes we don't always have an answer in research, in which case we fall back on clinical expertise. And then an individual touch, because not every patient's the same, right? So if one treatment option is quote unquote the best, but it costs thousands of dollars, not every individual might elect to have very expensive surgeries that are the best. They might choose a better option for them financially. Okay, so the goal is we're always trying to be our most efficient, right? No one likes to waste their time. No one wants to waste a patient's time. We want to do what's best. We want to do what's the most efficient and accurate at the same time. So I kind of mentioned already, but if your patient doesn't have unlimited financial resources, and they're electing something that's 85% as good as the best option, that might be good enough for them. And then here's another big thing, right? Let's use the example in the shoulder. There's over 150 special tests in the shoulder that are reported in the literature. There's no way, like when a patient with a shoulder injury comes in, you're going to do 150 special tests. So the goal is like, how do you prioritize based on their signs and symptoms and other test results? What is the best thing to do? So I mentioned research is important. Oh, that's not the garbage man. If you guys can hear the truck in the background. So our evidence-based practice starts in the scientific literature, right? Peer-reviewed. What that means is scientists and researchers, they send their papers and manuscripts into a journal. Their information is stripped away, so you don't know who it is or where they're from. And then there's blind reviewers, right? That's what peer-reviewed means. It's totally blinded to who the researchers are and who the reviewers are. That way, everyone's giving honest opinions on the quality of the research. These are the journals I recommend you guys start reading. Hopefully my little picture box isn't blocking you. But the highest quality journals are the 2 on the right. American Journal of Sports Medicine, so that's from the American College of Sports Medicine. MedSci is ACSM, so Medicine and Science in Sports and Exercise. That's from the American Academy of Sports Medicine. And AJSM, American Journal of Sports Med, is designed mainly for surgeons, so like sports medicine doctors and surgeons, but it definitely has implications for clinicians. And then some others you might be familiar with: Journal of Athletic Training, Journal of Orthopedic and Sports PT, so this is the main one that physical therapists use, JOSP. And then for strength and conditioning, JSCR, Journal of Strength and Conditioning Research. So I review for Journal of Athletic Training and JSCR. So as a reviewer, I get blinded studies that I get sent all the time. I usually average about 10 per year that I review. You give them feedback and whether or not it's publishable or not. So in the scientific research, the highest level of evidence is a meta-analysis, which is kind of like a systematic review, if you've read a systematic review before. But the difference between that and a meta-analysis is this combines similar studies and applies statistical models to them. So the example is I study ACL tears. I have a sample of 18 to 20-year-old college athletes who play soccer. A researcher in another state or country has the same exact demographics and they're studying the same thing. And then a third person comes along and combines all of those. So the highest level of evidence are well-designed meta-analyses. Whenever you're researching a topic, these are great places to start because it gives you all the known information already on what's out there. Okay, so next level down, randomized control trials. So randomized means everyone has an equal chance of being allocated to either a treatment, an intervention, or a control group. So let's say, like the easiest example are drug studies, right? Take a group of 1,000 people with cancer, 500 get a placebo, 500 get a new drug, and everyone's blinded, so no one knows who gets what. And then you see how they change over time. And then cohorts, case controls, case series, a little bit lower in quality because there's usually not randomization. It's like if you say, like, we're going to grab these 5 soccer teams and study them, there's not really any randomization. Those are more cohorts. Lowest level of evidence, someone's opinion. If you do not have facts and science to back it up, your opinion it may be worthwhile, it may be worthless. It just depends on where you're getting it from. Right. So my best advice to you guys is start reading these now. If you want to be an expert in your field, you have to know what the current literature is. Every week, these are the 5 I review for abstracts, and then I read the articles that are interesting. Okay, so let's focus on, now that we know where the information is coming from, how does it apply to us clinically? So we use diagnostic tests. So the example is torn ACL, or in the shoulder, I said there was 150 plus tests. So which ones are worthwhile? Which ones are worth their time and which ones are accurate? So step 1 is, what is the reliability of a test? So we have 2 different kinds, intra and inter-rater reliability. Remember, inter means between 2 things, and intra means within 1 person over time. So let's do an example. I perform the Lockman's ACL test on 10 consecutive patients. My partner who works in the clinic with me, he does the same 10 people. And then we compare, like, I had 7 out of 10 positive, he had 8 out of 10 positive, and you can come up with an agreement of how reliable a test is between different people. Different example, let's say I do the same test on the same person 10 times in a row. That's intra, that's just within me. Do I get the same result 10 times in a row? If I get 50%, right? Let's say I did the same person 10 times, and the 50% would be 5 times I said the test was positive, 5 times I said it was negative. That's not good, right? If I'm a clinician and I don't have internal or intra-rater reliability, then you're not performing the test accurately. If you've had stats, you might remember ICC's inter or intra-class correlation coefficients, where you see this little R value. So 0.84, that's pretty good. So here we see more about correlations. So let's say this is me on the bottom line on the x-axis. Say every time I have a positive result, someone else who works in my clinic, they also get a positive, right? So that's a 1.0 agreement right down here. So if every time I say the test is positive, he says it's positive, or she says it's positive, when there's a complete agreement and a correlation, it has this 45-degree angle slope, right? So I say yes, he says yes. Opposite, every time I say yes, he says no, right? So there's a negative correlation, that's not good. And then 50-50 split, right? Not good. Okay, so how do we apply that? So let's look at an example. Oops, go back. Let's say we want to test ourselves in the example of the torn ACL. So when I am in a clinic, or let's say I was in the athletic training room, a patient has a torn ACL and I perform a special test. These are my two options, right? I can say the ACL was torn, which means it's a positive test. Or I can say, that infield was still firm. I think the ACL is there. The test is negative, right? So these are the two clinical options. Then a week later, let's say they have surgery. That's the gold standard, right? Surgery, because they look inside the joint and they say like, yes, it's torn, or no, it's not, right? So torn means positive. Negative means the ACL is intact. And then you see how you lined up, right? So if I said the ACL was torn, they had surgery and it was torn, that's a true positive, right? If I said the ACL was torn and I thought the test was positive, but they went in and had surgery and they're like, oh, you were wrong, false positive, right? So this top row relates to your clinical test, right? A true positive, it was torn. False positive, I said it was torn, but it wasn't, right? You don't want false positives. Down here, similarly, right? I say the ACL is intact because I feel that firm endpoint in the ligament. And then when he had surgery, they saw it was just a torn meniscus, right? So the ACL was normal. Dang it, clicked again. So true negative means I was correct in saying it was negative. False negative is I said the ACL was normal, but in surgery they saw it was torn. So I was wrong. False negative. So the trues and falses refer back to what you did as a clinician. Okay, so then remember, let's look at the false positive over here. You said it was positive, but it was wrong. A man can't be pregnant, right? So false positive. Test, if the test says he's pregnant, wrong, right? False positive test result. Conversely, if you say the woman is not pregnant, when she clearly is, you falsely said she wasn't pregnant. That's a type 2 error. Okay, so from that, we can build these math equations to help us think about if a test is sensitive or specific. So these are important terms you're going to need to know when we're learning the special tests in each joint. You're going to have to know the reference values so you can see the accuracy of each test, right? That's going to be important. So sensitivity. Does the person have the pathology, right? That's the easiest way. If a test is sensitive, it's good at capturing the people who have a torn ACL. You can see where we get these numbers, right? So 17. How many times was I correct in saying the ACL was torn and they did have a torn ACL? 17 divided by the total number of people who had torn ACLs. So you're creating a rate of how many times were you correct based on how many people had the injury, right? Sensitivity. 74% isn't good. You'd like that to be like 90% or higher. And specificity, in people who are uninjured, did the test come back negative, right? So we have to go to the negative column. You can see we have now we're over here, these two. How many times was I correct? 14. So in 14 healthy people, I said the test was negative and I thought the ACL was normal. I incorrectly had 3 false negatives. So 14 divided by 17, 82%, right? Not terrible, but we'd like it to be 90% or higher, or 0.9 or higher. Okay, so make sure you understand false positives and negatives, true false positives, true positives and negatives, false positives and negatives, and how they relate to sensitivity and specificity. Okay, so another value you're going to see in the book, positive and negative predictive values. We're not going to get too much into the calculations, but just remember, we want those same kind of 0.9 or higher. Okay, so I want you to think about an example of where you're shooting archery I don't know if anyone's done archery before or use a bow. Obviously, this one's the best, right? You get the same result and you always hit the bullseye. That's high reliability and high validity. Think about which one of these is the worst. Let's say you're a clinician and you're testing people's ACLs. Which one do you think would be the worst? Is it this one, or this one? So I think in cases where you have low reliability, you're always getting a variation of positive and negative results. So even though you're kind of in the same pattern here, this is all over the place. So most people say like, oh, this one's the worst, but it's actually not. This one is the worst. You get the same result every single time, but you're wrong. So the concern is that you don't know you're wrong. Like imagine you had 100 people with torn ACLs and you didn't know you were doing a test wrong, but you always get the same result. So this one's kind of the most dangerous clinically. You're doing something wrong, but you don't know it. So hopefully you can catch those. All right, so that is the end. We had a quick one for chapter 3, evidence-based practice.